Hello, everyone. My name is Marcela Garcia, and I'm a columnist and associate editor with the Boston Globe's opinion section. I'd like to welcome you to the Globe's first Health Equity Week, a week-long series of events timed to recognize Pride Month and Juneteenth, as well as Immigrant Heritage Month. The idea is to unpack crucial conversations around health equity and bringing together health system leaders, medical experts, and community advocates to discuss ways to reduce disparities and advance more inclusive care. To kick off Health Equity Week, we have a fantastic leader and expert to discuss a very relevant topic: how to combat mistrust in health institutions. Before I introduce her, I'd like to remind you that we are going to leave about 15 minutes for audience questions at the end of the panel, so please feel free to submit those through the Q&A function at the bottom of your screen. And now, it is my pleasure to welcome Dr. Bisola Ojikutu, the Executive Director of the Boston Public Health Commission. Dr. Ojikutu, thank you so much for joining us.
Thank you, Marcela.
So I like to begin with a very simple question. Mistrust in medical institutions is a very broad umbrella of problems and factors and so forth. So why don't we begin by defining terms and actors when we talk about medical mistrust in healthcare? Who are these institutions we're talking about, and how would you define medical mistrust?
I agree that the term medical mistrust is somewhat unclear and oftentimes it's ill-defined. So I'll try to provide some clarity. But I'll start by mentioning that prior to becoming Commissioner of Public Health in Boston, I was a clinician and a health equity researcher. And some of my research and publications are actually focused on medical mistrust among people of color, particularly as a barrier to accessing HIV prevention, care, and treatment. So my responses to this, as well as to other questions, it's really going to be based on my experiences as a leader in public health, but also as a doctor with practical experience and a researcher that's done the work in this area. So what is medical mistrust? In the literature, medical mistrust has been conceptualized as the absence of the belief that healthcare providers and healthcare institutions, including clinics and hospitals, genuinely care for patients' interests, are honest, are transparent, and will provide the highest quality of care to them or to people who look like them. Take it one step further, medical mistrust has also been conceptualized as the belief that healthcare providers and healthcare institutions are overtly acting against the best interests of certain individuals and populations. So you use the term actors. I like that term. So who are these actors who are not trustworthy? I mentioned healthcare providers and healthcare institutions. Is that really it? Well, much of the literature on this topic really is talking about that one-on-one relationship between patients and doctors and patients and healthcare institutions. But there is a move, and there's other literature and researchers who want to take a more broader and expansive view of who those actors really are. Who is it who isn't trusted and who isn't acting in the best interest of communities? And I think that's really important. It acknowledges there are many actors within our healthcare ecosystem who have not been deemed to be trustworthy. That may be health insurers, that may be the pharmaceutical industry, it may be the government as a steward of the public's health. And just lastly, I want to mention, what about research? So one comment that is important to note is that there's a lot of research-related mistrust within certain populations. Well, medical mistrust is significantly associated with lower involvement in research, particularly biomedical research. Thus, medical mistrust promotes mistrust in researchers and research institutions, research studies, and new advances in medical research like COVID-19 vaccines. So researchers and research institutions are additional actors, if you will.
And I would think that when somebody mistrust a medical institution or a medical actor, that mistrust probably transfers right to other institutions, because once you have an interaction that is not trustworthy, you probably are more likely to trust other similar institutions, right?
Absolutely.
So where does medical mistrust come from? I mean, you did mention something about interactions in particular areas or institutions, also some historical factors, right? But it's not just related to these past legacies of racism or mistreatment that a lot of people know about, but it's probably perhaps worth mentioning. But it also comes from contemporary experiences of discrimination or experiences of bias in healthcare. Could you expand on that a little bit?
That's absolutely right, Marcella. Medical mistrust amongst people of color is born of a long history and it's important to emphasize, and current experiences of racism and discrimination within systems and institutions. So again, not just healthcare systems and institutions, but our system just across the board. And there is significant evidence that what happens within our communities outside of the healthcare system significantly impacts how we perceive healthcare and our interaction with healthcare institutions. So many people have highlighted specific historical events as a trigger for medical mistrust within communities of color. But I think we need to be very clear here that there is no one event. No one event triggered mistrust within Black communities, within Latinx communities, within any community. I think that if I could make a recommendation, Harriet Washington's book on medical apartheid details the long history of medical experimentation and research malfeasance involving victims of color. And I think that it dispels the myth that there was one particular event. But even beyond that, medical mistrust is not just about these overtly egregious acts of medical experimentation and research. You know, it's not just about what's so obviously wrong to some people. Medical mistrust is honestly the result of exposure to chronically adverse circumstances. It's about chronic baseline inequity manifested as things that we see all the time: limited access to high quality care, poor experiences within the healthcare system, perceived racism and discrimination within the healthcare system, longer wait times, and also just similarly observing more illness, worse outcomes, and premature death amongst people who look like you.
Yeah.
These are current events. This is today. And even if you have not personally experienced it, there's transference within communities, within families that perpetuates mistrust. And I want to emphasize that oftentimes mistrust is viewed as like some kind of a pathologic thing within people of color. Like, oh, they don't trust anybody. Mistrust of the systems and the people who have treated people who look like you and you potentially poorly, that is a normal and rational response. I also want to just add two more points that I think are really important here. Medical mistrust is also about not seeing many people who look like you delivering healthcare services and leading research, people who are native speakers of your language providing the services. And it's also about things that are happening outside of the healthcare ecosystem. Now, I mentioned this, but I want to emphasize that it's about structural, social, political, economic exclusion and marginalization. People trust what they feel a part of. If they don't feel a part of the healthcare system, if they don't feel part of research institutions, they're likely not going to trust it. So simply put, medical mistrust is about systems and institutions that have existed in this country for centuries that were never designed to be inclusive, never designed to be diverse, or to promote equity and to be trustworthy. And until we recognize this fact and actually create structural change, there will always be medical mistrust.
I love that point that you mentioned about sometimes people of color labeled as the problem. I mean, not in such a specific or explicit term, but sometimes they're like, oh, they're non-compliant, or they don't want to go to the doctor. They don't want to follow, like they don't want to go to a preventative healthcare appointment, and that's on them. And that is such a misguided view, because it really is about the systems, and the onus shouldn't be put on, you know, the victims, basically, right? And the other point that you mentioned too about cultural competency too, right? Like the importance of having someone who understands not just your language, but someone who looks like you and who can understand where you're coming from. I mean, there are so many. I think about, obviously I'm Latina and I grew up in Mexico, and there are so many idiosyncrasies, right, around Latino healthcare, like this idea that my dad was this way, that every single thing could be cured with vapor rub. You know, this is a thing about Latino households, and people in the audience would totally relate to this. Like he would use vapor rub for everything. He was convinced. So the importance of having someone listen to you and not dismiss those things and not label you, you know, ignorant or non-compliant. I think it's a point that you made that was very compelling in the context of the topic, right? So talking about outcomes, right? Like, how does maybe this is an obvious question, but if we can unpack, how are the ways in which medical mistrust contributes to health disparities? Like, help us understand, right? What is the cost of having communities of color mistrust healthcare providers, and how that untrustworthiness affects us all, not just Black and Brown patients?
This is a great question. Researchers have been studying medical mistrust for decades. This is not a new concept at all. Of course, it was elevated during COVID-19 as we tried to roll out vaccines and other aspects of care and treatment. You know, medical mistrust provides a partial explanation for the overwhelming health inequity and disparities in health outcomes that are evident by race and by ethnicity throughout our country. But I think we need to talk specifically about what we know it's associated with. Medical mistrust has been associated with underutilization of health services, delays in accessing care, as well as preventative services like cancer screening and use of pre-exposure prophylaxis for HIV, which is one of the things that I've studied. It's also been associated with poor management of health conditions, including diabetes, including cancer, including HIV infection. And it ends up leading to premature mortality, amongst our residents. And if you look at some of our Health of Boston data, you'll see a leading cause of premortality is diabetes and cancer. So it's a very important concept. I think it's also important to think about how medical mistrust inhibits uptake of therapeutics and vaccines, because if you're not listening to your doctor, if you're not following what they've prescribed, what they've suggested, because you don't trust them, that's a major issue. And certainly we saw that as a major issue during the height of the COVID-19 pandemic. It's also interesting that, and this is something that you alluded to when you were talking through this issue of people being heard and being understood. When you have medical mistrust, that hampers the patient-provider relationship. It limits communication between patients and providers. You should want to tell your healthcare provider anything, but if you don't trust them and you don't trust the system that they work for, you're not going to share critical information. You're not going to share details like you use VapoRub. I mean, I'm just saying, you know what I mean? You're not going to share it.
Right.
You're going to say, oh, they're going to look at me like I'm
silly.
ignorant.
Yes.
Right, I'm silly. But you're also not going to share things like risk factors. Like
Totally.
if you're engaged in any sort of behavior that could impact your health long term in a very serious way, you're not going to share that unless you actually trust the person. So overall, it negatively influences patient behavior and leads to poor outcomes and promotes disparities. So here's a question though, and I think you alluded to this at the beginning when you said, so why should we care? If when I say we, I mean the big we. I care. Right. I'm Black. You care.
Yes.
As you said, this is our experience, but the rest of the world should care too. And there are many people who do care, but I think we need to think about that for a minute. How would this impact everybody so that we can actually do something about it? Well, certainly there is the moral argument. Obviously we as a society should care collectively about the health and well-being of others. And I think a lot of people do care, but we need more than that sometimes. We in order to really drive interventions forward and change things, we need more. So there's also the economic argument. Blue Cross Blue Shield Foundation of Massachusetts, in collaboration with the Health Equity Compact, which is a collaboration of more than 70 healthcare leaders across the state, of which I am a member, most are people of color, released a very critical report last week that gives us all reason to care about inequity and challenges like medical mistrust that promote disparities. Their study found that the cost of health inequities experienced by Black, Latinx, and Asian individuals in Massachusetts totals approximately $5.9 billion each year. Okay, when you think about it, that's an overwhelming amount of money.
And that's in the state, right? That's in Massachusetts.
That's just in the state. That's just in the state.
That's just,
yes, that is just in the state, and that's each year. So 1/4 of that is the cost of avoidable healthcare spending due to poor health. People delayed care, just people presenting with very poor health. Another 1/4 is lost labor productivity due to poor health. So people leaving the workforce. And another half is the cost of premature death. Okay, so and let's go back to the Health of Boston reports that I mentioned that are online. Premature death increased more than 37% for Black individuals in Boston, where essentially it's remained the same for other populations. So when you think about what's happening amongst our people of color right here in the city, in the state, it's incredible. Even more stunning, they found that if no action is taken, if we don't do something and do something now, the economic burden of health inequities will almost double in a generation, from 5.9 billion each year to 11.2 billion each year by 2050. So, I mean, this is just incredible. And it's something that we all should care about. The Health Equity Compact filed an act to advance health equity, which is legislation aimed at a lot of these issues, prioritizing health equity in government, reporting on health equity data, improving access to care, and all of that, and diversifying the workforce is another piece of it. But all of that, it will help to address medical mistrust. So we have to all care. We all have to commit to addressing it.
Yeah, that act, that legislative piece, I think it's important because all of that, I think the sum of that, the collection of the data, it's an important part because sometimes we don't even know what the problem looks like, right, in terms of health equity, right? And so unless we know the size of the problem and the reasons, which, like you said, medical mistrust could very well be one, then we are not going to be able to sort of tackle it. So that piece of legislation is, I think, a critical one that the Health Equity Compact, like you mentioned, is advancing and that people should really get behind, right? And so I guess that, moving on to remedies, right? The $1 million question. How can a medical organization that thinks that they have a problem with medical trust or all of the other actors involved, how can they earn the trust of communities of color who may be reluctant to seek care due to barriers, right? Again, like medical mistrust. What are some proven strategies that healthcare institutions can use to address mistrust in the populations that they serve?
Mhm. So literally, that's the multi-billion-dollar question.
Right.
It's not just a
Not the
multi-billion-dollar
$1 million.
question. Right. But I really appreciate how you asked the question. Medical mistrust, as I said, is often characterized as a problem within us, as opposed to it being a problem within the systems. And
Right.
we know that the onus should not be on us to do anything. Should not be on patients. It really needs to be on the systems to change and to prove themselves to be trustworthy. So, I think the answer is multifactorial, right? And I think that there isn't a huge, great evidence base, but I think there are things that are just sort of obvious, and there are things that relate to some of what we've discussed thus far. But I would sum it up by saying this morning that what we need is structural change. And by that, I mean, we need a dramatic and intentional shift in the way our system operates. I think there needs to be a recognition that it's now time to shift. We saw all what we saw during COVID-19 as we prepare for next, sort of pandemic, as we think about what needs to change within our communities, and as we address this huge economic and moral issue regarding inequities, we actually need a shift. The same old things that we've been doing, it's not working. Okay. And I think that's, if there's anything you take away, it is
Right.
we need to do something differently. So what I would say is that institutional practices need to change. And I think there's movement certainly in this direction. I think being more transparent with data, with best practices, who's getting what and who's not getting what is known and what is not known. It is so critical to be able to say to your individual patient or to patients in general, we don't have an answer to this yet.
Right.
We don't know the answer. And I think people appreciate that. Like when I share that with patients, they're like, okay, I get it. You're still working on that. Let's work together. I think creating welcoming and inclusive environments is so key. I remember walking into a very large academic center, not here in Boston, but in my home. I'm from the South Side of Chicago. As a younger person, I had an injury and, I was coming in, I was terrified, not just terrified because I, had an injury, but just the size and the fact that I didn't see anybody like me, except for people sitting in the chairs, it just wasn't inclusive. It didn't make me want to be there. I think involving patients in decision-making is not something that we always routinely do. Actually appreciating their expertise in their illness, so why is it that you do X within your culture, within your family, you yourself for that particular illness? Well, tell me because there may be nuggets there that we don't know are actually important, and treating people like they're an expert in their area.
Right.
You know what I mean?
Right.
Treating them like that, as opposed to imparting your beliefs on them or whatever your culture believes on them, thinking about them as an individual who's living within a larger structure of a culture, a community, and has their own lived experience, which is critical. We've already said this, but being more diverse in general. So we saw during COVID-19 how well trusted messenger programs worked, where we had not just healthcare providers, but we also had community members who were racially and linguistically concordant with the populations that they wanted to connect with. We had them talking to the community about evidence-based data, debunking myths, attempting to build trust in COVID-19 vaccines and testing and treatment. And it's really staggering when you think, Marcella, about how few Black and brown doctors there are in this country. If you look at American Association of Medical Colleges data, there are only like 5.8% who identify as Latinx and only 5% who identify as Black or
That's
African.
crazy.
It's crazy when you think about our demographics in this country. It just does not make sense. You know,
Right,
it's not how you treat people, how we should be thinking about the future and how we should be treated.
Yeah, right.
You know, I would also say that interactions within the clinical encounter need to change. And this is something that I have worked with some other researchers in thinking about a curriculum, you know, and how do we teach people how to act? How is it that you establish better relationships with patients? And I'll tell you, Marcella, as a practicing clinician, I know when a patient is not necessarily trusting me or when they are feeling me out to see if they can trust me, you know? And I think that's an important thing to have a sense of, you know what I mean? To walk in and say, you know what, I need to build a relationship with this patient. I need to be trustworthy in order to benefit, in order for this patient to benefit from being here. So I think all healthcare providers of all types, whether they be doctors, nurses, whatever, need to evaluate their communication styles, and we need to fund and look at these curricula and get a sense of how well they should be expanded within both medical schools and beyond.
Yeah.
You know, when people feel that racism and discrimination are playing a role in their interactions, it really breeds medical mistrust, and patients will just disengage. They'll just be lost to follow-up. You'll never see them again. And when you think about all the illnesses, whether they be communicable or otherwise, that are not being treated out there, I think that's a major problem. And I would say, just to anybody who's listening, there are some simple communication tools, just using open-ended questions. Using reflective listening. So actually, when somebody says something to you, reflect back to them, you know, what they said, to acknowledge that you heard them, showing that you care about people holistically, not just asking about their diabetes, asking about, how's your daughter doing? You know, how's your family going? How are things happening in your job? Fully hearing people's concerns. All of this demonstrates empathy. And I think that there's a move towards more of that within our healthcare system, but it's not there yet. Okay, it isn't. And I think part of it is that, you know, clinicians, people who are working with patients, they have a limited amount of time. I completely understand. But certainly trying to use those strategies. I think that also medical education needs to change. So there's something called structural competency. And it's different from cultural competency, different from, you know, even cultural humility. It's really about understanding the ways that systems, institutions, neighborhoods, policies, socioeconomic issues, the healthcare system, how it actually shapes the patient's experience and outcomes. Now, when I was going through medical school, we didn't talk about these issues. You know, we just said, okay, John Doe is arriving and he has out of control diabetes, so let's just give him more insulin and move on. You know what I mean? Without trying to think, what is it about his situation at home? What is it about the policy and the cost of insulin? And you know what I mean? What is it about all these pieces that are stopping this person from getting to where they need to get in terms of managing their healthcare? So really, what I would like to see is not only for more healthcare providers to have that structural competency, and again, I think that there's a distinct move in this direction at most, if not all of our healthcare institutions. I want to see healthcare providers advocating and mobilizing to address health inequity in this way and taking off their blinders, you know what I mean? Because I think that happens, and actually recognizing that the time to act is now. And then lastly, on this topic, and I think it's important, this is maybe the most important, maybe not, but it's one of the very important pieces here, is that I already stated that medical mistrust isn't just about the healthcare system. Change needs to occur outside of the institutional walls. There are ripple effects. When something happens in one's community, when people see, there's actually a study, when people knew about or observed police brutality, it actually impacted how they interacted with their healthcare provider. You see what I'm saying? Because institutions, people see institutions as part of a whole. Do you know what I mean? So we need to create meaningful relationships, authentic community partnerships and collaboration, working with, not just within communities. And I think a key piece of that is sometimes challenging for our systems is it does mean shifting power. And what I'm saying there is talking about changing the imbalance of resources and investment so that people in communities come to the table and they can be more on par, with the people who are really historically known to have the power. Do you see what I mean?
Right. Yeah.
Like if you really want to partner, people have to feel like they can come to the table. They are emboldened. They are empowered. Exactly. That's exactly right, Marcella. And we have the power to start thinking about how to do that more routinely. That is how I think you create change. So those are the things that I think make sense. And certainly I know that there are other strategies, and would love to hear that from the listeners, but those are the strategies that I think should be moved forward if we really want to address medical mistrust.
No, that was super comprehensive, Dr. Ojikutu. I mean, it just really goes from the very basic, simple, and almost kind of easy to dismiss, but like, that interaction that you mentioned that you had when you were younger struck me, because sometimes it's really literally at the beginning, is that first touch point that you have with the system. And if you perceive that you're being dismissed or not listened to, or if you don't see somebody that looks like you, or if you cannot communicate, if there's not an interpreter, that is immediately going to impact the whole interaction. And it's just as simple as having a welcoming, lobby. Again, it just sounds so simplistic, but it really isn't.
The interesting thing, Marcella, that brings up is, oftentimes when I talk to patients about their experiences, they'll say, they left me waiting in the waiting room.
Yes.
Nobody came and told me, oh, I'm next, or how long did I have to wait? Nobody tried to make me feel comfortable here. It's simple things like that. That simple human touch point.
Correct.
You know what I mean?
Correct.
He's saying the doctor is busy, the nurse is busy. Please give us 10 minutes. I will check back in with you. Little things. It's really
it is as simple as that. And so speaking of all these solutions and remedies, are there examples? Just thinking about real life examples and how this looks like on the ground, right? Some examples of solutions that have come from the disadvantages or disenfranchised populations themselves about how to tackle mistrust in medical institutions, even though the onus should not be put on them, but are there examples of populations taking charge, feeling empowered themselves and say, hey, let's do something about this?
I think this is a great question, and it's something that we've written about in the American Journal of Public Health. Medical mistrust can actually be an impetus for communities to mobilize. It can actually empower both individuals and communities to create change when it's channeled effectively. When I say this, oftentimes people are like, what? That doesn't make sense. So is medical mistrust a bad thing or a good thing? Well, no, I think that, bad, good is not really the answer here. It's how it's being utilized. So let me give an example, and I can use just the COVID-19 pandemic as an example. So the pandemic itself and really incited a groundswell of activism as well as empowerment. We all saw this. And as data regarding disparities became clear, it's March 2020, April 2020, then we see vaccine trials and then the vaccines being rolled out. Coalitions across the country comprised of Black, Latinx, immigrant individuals, Indigenous folks, they arose, they got themselves together, they got on Zoom and they said, look, we're going to provide education to people who look like us, sound like us, speak our languages. We are going to be boots on the ground. Where everybody's locked up, we are going to be boots on the ground. We're going to get out there and we are going to try to improve uptake and access to vaccination, as well as, testing and treatment. And we're going to do it because we don't think anybody else is going to do it. And not do it equitably. And they also, not only did they do the clinical pieces and the education, they also address social determinants of health, food insecurity. They helped with a lot of these issues that, were not necessarily, that became worse during the pandemic that we know that was happening. And they provided social and psychological support to a lot of people who were very isolated. Right. And so I think the question about medical mistrust is, as you think about why this occurred and is it something that we can think about? How do we harness going forward?
Right,
You
right.
know, so at the time, there was this clear need and feeling that community members must step up. This is life or death, and
Yeah.
serve their own communities. And I think, at least in the meetings that I attended, just a lack of trust, which was common sense, that others would do it in a way that would be transparent, that would be as available as they needed it to be, and that would place the best interests of the community as a top priority. So there was this clear history, current circumstances, contemporary, led to this sense that, okay, we need to jump in here and get this done, because if we don't get this done, we are going to die. You know what I mean? There was that sense. And so these efforts were really motivated by centuries of structural racism, marginalization, and rational mistrust that current systems of power would not fill critical needs equitably. And like I said, this happened across the country. And I think, these community coalitions were really instrumental here in Boston, particularly in closing disparities in vaccination, which we actually closed in April of 2022. Our numbers actually, they increased, and we, were able to do things that other cities were not. And I think that's an important piece of this. And so, when you think about the Black Boston COVID Coalition, La Colaborativa, Equity Now and Beyond, these other just groups of people who said, we can do this, we can harness the resources. But it's important to note that they were funded to do this. You see, they were funded. So they had resources. So that issue of shifting power, it happened there because there was a need to happen there. So my question, and the question that we're trying to deal with here at the Boston Public Health Commission, is, can you imagine what could be achieved if these same or similar community coalitions were to continue to be mobilized?
Right.
You think about all the inequity and all the challenges that we just talked about in terms of the economic ramifications of disparities, and just a lot of the things that we've reported on in terms of Health of Boston. What if they were funded to do this same work? How powerful would that be? And how much trust would be built? Having them truly as part of a system, not as an add-on or an adjunct, but really a part of this healthcare ecosystem.
I mean, it would be a multiplying effect. And it would also, again, like you said, it would sort of transfer or have an impact in other like diabetes care or any other type of disease that is prevalent among these groups. I mean, I do remember your point about the addressing also the social determinants of health, like the food insecurity that we saw throughout the pandemic. And you mentioned La Colaborativa in Chelsea. I mean, they were giving out food. And I also remember at the time, like you said, attending Zoom meetings with, leaders of color. How do we reach the Haitian community? How do we make them get the vaccine? How do we combat misinformation? And I remember some strategies being so simple, like we can give them a $25 gift card. And I thought that was brilliant, because you are addressing a need that this population has. Well, at the same time, you're saying to them, look, this is something that can be trusted. You can trust us, and we're also going to help you buy groceries for your family. And I mean, but you're right. I mean, I guess the challenge is to continue it, right? Moving forward after, I don't think we can say, well, some people say we are out of the pandemic. I don't know, but it's still continuing. So can you talk also about the Boston Public Health Commission itself, like the work in the commission? How is it tackling some stark health disparities in the city, including instances of medical mistrust, if you know of any?
So the Boston Public Health Commission is, obviously our city's health department. It's one of the, if not the oldest health departments in the country. And interestingly, when I, was just starting in this role, as I was looking back through the history and old documents, I realized that we've been doing racial justice and equity work for decades, really have been investing and thinking about how to engage partnerships and build the type of community coalitions that are about addressing medical mistrust, about creating systems that are led by communities, by people who look like those people who are in the closest to the pain, which I think is very, very important, a very important concept. I think one of the interesting things about the Boston Public Health Commission is that we ourselves internally have been working on our own issues of racism. So we I think, what's important here is that I believe that institutions themselves need to work on racism within their own organization. They need, as I said, to have more people leading them that look like the communities that they're trying to serve. We ourselves, we have an anti-racism policy and ways that we connect with the community in an equitable way, which I think is incredibly important. But let me give two examples in terms of specific disease entities that I think are not, specific issues that we're very concerned about. So everybody is talking about life expectancy, right? So everybody quotes data on life expectancy. We recently released data demonstrating that there is approximately a 23-year life expectancy gap between a census tract in Roxbury and a census tract in Back Bay. And I think the question here is what's causing that life expectancy gap? I mean, it's not that it's new. It was larger than that. Before it was 33 years, youth looking at older data. But what do we do about it? And we need a plan, and we're certainly working on this. But one of the immediate strategies is to fund those community coalitions that I just talked about to do the work in Roxbury, but also in Dorchester, Mattapan, and East Boston, and other neighborhoods where we know that there are ongoing concerns, to work with community health centers and engage and work similar to what was successful during COVID-19. So boots on the ground, linking people to care and services, increasing health literacy, thinking about robust approaches to addressing social determinants of health. Certainly, I think there's much more that we need to do to actually shift life expectancy. It'll take a collaborative effort across many partners, across many city departments, but this is a start. And I think it's an important start because it builds on what we learned during the pandemic. I also want to talk about maternal morbidity and mortality. I think it's a key issue because, it's interesting, Marcella, if you think about how to assess overall community health, there are really two measures you're going to look at. You're going to look at life expectancy, which I just talked about, but you're also going to look at infant mortality. Those are two things. When we think about countries, states, whatever, you're looking at those two as barometers of how well we're doing. So according to data compiled by Boston Public Health Commission, for every year between 2017 and 2021, Black Boston residents experienced the highest rates of low birth weight infants, preterm births, and infant mortality compared to all other races and ethnic groups. And this is very disturbing to hear, but infant mortality is 3 times higher among Black newborns. So 9.7 deaths per 1,000 live births compared to white newborns. Okay, so this is something that is, again, striking data that we need to do something about. I would say, though, that things are getting better. One of the programs that we have in place, the Boston Healthy Start Initiative, really looks to focus in on promoting health and well-being, not just of the infants, but certainly of the entire family. Okay, because it really is about not just managing the person who's pregnant and the infant. No, it's about the entire environment that the child and the family is existing in, which is incredibly important. And as a testament to its success, this particular initiative, Boston Healthy Start Initiative, has been in existence for 33 years. It's one of the oldest programs at the Boston Public Health Commission. It is trusted and it is a valuable program in the city. And like I said, we've noted improvements in infant mortality, low birth weight, and preterm births over time, but there are still disparities, which speaks to the broader issues going on here, the social determinants of health that we know within communities we need to deal with. So what we do is we provide health education, nutrition, prenatal education, parenting education, which is incredibly key. And then, I think this is very important to talk about. We do provide mental health counseling, because that is an enormous issue that we know we're dealing with, and it has been, increasingly causing challenges for not just, pregnant individuals, but certainly beyond that.
Yeah,
I think programs like this work, and they're ones that have been funded, and they're ones that are important to our city. But I just have to end this, this discussion of this particular program by saying we still need overarching system change. We can continue to do programming, but we really need system change.
I mean, you did say something to me earlier in a previous conversation you and I had about taking time, right? This doesn't happen overnight, that we have to be patient, but also deliberate, intentional, but it's not going to happen overnight, correct?
Yes. I think a lot of people have talked about, and I was on a recent panel with a colleague talking about sort of moving at the speed of trust, that overcoming all of these issues that we've discussed this afternoon, this is going to take time. It's not one strategy. And as I mentioned, there are lots of different strategies. There really is intentional investment that it is going to take to change things, to cause the structural change that's necessary to address medical mistrust. And you can move forward with programming, but it's only going to work if you're simultaneously, or if you have built the trust within the systems, within the communities that you are trying to impact. So
Right.
it is incredibly important, but it's also incredibly important, and I'm glad we're having this discussion, to be intentional about it, to acknowledge that mistrust is there, and to say, how do we as institutions become more trustworthy, and what are the steps that we need to take to get there?
Yeah. Well, with that, let me turn to some questions that were submitted previously by audience or people interested in the topic. There's a very straightforward question that I wanted to mention. Somebody's asking about resources for details on working with various ethnic leaders to connect to consumers. Sometimes, like we talked about, like you mentioned with COVID, it was community leaders that had the trust of the population, and that they were sort of empowered themselves as well, like through funding or through government entities, to help send a message to these communities. How can people connect to these leaders? Sometimes we don't know, there's a lot of immigrant communities that have leaders that obviously we not all know about. Do you have any suggestions as to how to connect with some of those leaders?
So I think that if you are interested in connecting with and building coalitions, when I started in this role, one of the things that we realized is that we needed to have sort of a point person, a person who helps people, helps groups, organizations connect to other folks. And we ended up hiring Melissa Hector, who is our Director of Equitable and Strategic Initiatives. And so she is really the person who works with and has built a large community coalition of folks who come together every other week to talk about a lot of the challenges they're having. And certainly it includes individuals who are part of the coalitions that worked in COVID-19. And that was really the basis of the work, but it's continued. So please feel free to reach out to her. It's mhector@bphc.org. I've, told her that, people will be reaching out to get information about coalitions to work with. I think it's important for that work to get out there and for people to be connected. She can also provide you with the link and information for those meetings, because those are great community meetings to actually disseminate information and to start networking, and getting people to work together. The fund that I mentioned, she's actually leading that fund, the fund for community coalitions to work with community health centers. So an RFP will be released within the next week or so, and she has the information on that fund. So I think that is another piece of important information. And we will obviously, do a press release so people are aware that these funds will be made available.
Perfect. This next question is actually very, very specific and kind of very simple, but someone is asking, what specific advice would you have for people of color, BIPOC, to deal with medical personnel who are reluctant to believe or address their particular health concerns? Like what advice would you have for that person who is being turned away or not believed or dismissed?
Yes, I think that's a really important question, and it's a lot of people have that question. They feel like they're not being heard within the medical encounter. I can't tell you how many times people have come to me and said, well, I wasn't heard about this elsewhere, so I decided to come over here. I would say, if you are able, not everybody is able, if you are able to seek a second opinion and talk to somebody else, if you feel that something is wrong, something's not right, or if just your questions are not being answered, I think that is really going to be an important step for you. Two, I think it can be, particularly for individuals who maybe are less familiar with the healthcare system here in the US, or don't feel necessarily personally empowered, can oftentimes be concerned that they're, not getting heard and aren't sure how to sort of navigate around systems. Most of our healthcare centers do have a way that you can provide feedback, information, like a patient sort of information gathering. So I would look for that. I would ask the front desk, can I offer my opinion here because your voice matters. And I think patients need to feel empowered in the setting of whether it be healthcare or other, say patients, people need to be empowered. Just because something is being offered to you, it doesn't mean that it's necessarily what you need. It doesn't mean that it's necessarily the highest quality. You need to be asking questions. And I want people to feel more empowered to raise issues, to raise concerns, because if we don't fight for ourselves in a setting where we're, hoping that institutions will be developing and growing and becoming more trustworthy, then, we're going to unfortunately have poor outcomes.
Right. Just very quickly, someone's asking to repeat Melissa Hector's email in the chat. I'm just going to type it here. She said
mhector@bphc.org.
At bphd.org. I'm just typing it. All right. So one more, we have time for two more questions. So one, someone's asking about just basically the fact that building trust is going to take a while, right? While we are waiting for the system to be radically changed and the science shows that prevention and early intervention saves money, shouldn't insurance companies provide coverage for independent advocates to bridge the gap between providers, healthcare systems, and patients in helping patients and people to access the services that they need, understand their options, etc.? And the reason I think this is a doctor, she's asking because she has seen as a professional healthcare advocate, she sees how many times Black and brown patients are not getting prescribed treatments for type 2 diabetes, while any other white patients would almost automatically be given. This is what she's saying. I mean, what is the role of insurance companies? What should they be doing now?
So I hear you, and I think that that's a great idea. I think that though I said, just to clarify, though I said that we need, overarching structural change and a dramatic shift, there are incremental steps to get there. Like some of the things that I mentioned, I think are things that we can do starting today. Changing communication style, involving patients in decision-making, learning about, structural competency. But this idea of funding people to serve as professional advocates within the healthcare system, certainly that has been modeled. I like the idea. I think it works if people are willing to have somebody serve in that capacity. I think the idea of traditionally we say patient navigators, and oftentimes they will work in that capacity. I myself years ago had started a patient navigation program for women living with HIV. And so, trying to get them back into care, but then also making sure that they were asking the right questions of doctors, making sure that they felt empowered to question new antiretroviral therapy, question their lab work, the kinds of things that not everyone feels comfortable or even knows to ask within the healthcare system. Right. We also strongly advocate community health workers who can serve in that capacity in some ways by providing outreach, outside of the medical system in some cases, or certainly also inside the medical system, but understanding where people are and why they haven't been connected to care, and providing them and guiding them back into care, but also answering some of the questions that they may have. So I hear you. I think that would be a wonderful thing for there to be a more deep investment, and that health insurers widely fund those kinds of interventions. Absolutely needs to be done, particularly given all that we're seeing in terms of health inequity.
Yeah. So we have one last question. I think this is a good note on which to end this fascinating discussion. An anonymous attendee is asking, what can the average Boston resident do to help end medical mistrust and build trust between the health and public health care system and the city's residents? An average person wants to help. What can they do?
No, I think that's a great question, and it probably isn't one that I've thought as much about, which I think is like a great question. No, it's a perfect question to end this with, because I know that obviously there are lots of different people who are listening. Number one, avoid our own inadvertent spread of sort of misinformation. Now, the reason why I'm saying this is that we saw during COVID-19, but certainly we see in other issues, other health challenges, misinformation being spread, and misinformation helps promote medical mistrust. And certainly we don't want disinformation, which is intentional misinformation.
Correct.
If we don't know the answer, say, I don't know, let's find out. If you're talking to your friend, you're talking to your family member, I think that's really incredibly important. I would also say, just as an average individual, and I do this with my own family, because I think we as a family have had challenges, as most people's families who are people of color. You know, my father is an immigrant. You know, my mother's family, you know, have been in this country for a long time, and they have suffered, you know, the trauma of racism, you know, and
Sure.
racism within the healthcare system. And oftentimes when they tell stories, I try to sometimes redirect the story. You know what I mean? Because not because I don't want people to be aware, but I don't want them to not engage with the healthcare system. So
Mhm.
if they're telling a story, say, about poor way that they were treating the healthcare system, I say, let's find a different doctor. Let's find a different emergency room. Because what I've seen over the years as a doctor, people disengaging entirely. You know, they have one bad experience in one emergency department and they just say, you know what, I'm not going back again, period. I'll take care of it on my own. So it really is about continuing to encourage within our own social network. Think about your own social network, that people continue to engage. And when you engage with your doctor, you know, you have these conversations with them. You can say, hey, you know, I know that mistrust and medical mistrust, this is a thing. I'm going to tell you how I really feel about being here. Engage them in these discussions. I think a lot of healthcare providers would like to have these discussions and say, okay, let's talk more about diabetes treatments. Let me tell you what we know and what we don't know. And then take that information back within your own social network. I think these are things that everybody can do. Being aware there is a problem, but also helping with increasing people's access to information, their engagement and care within your own social network, because change does take time, but there are certainly things that we can do to promote change.
And certainly amplifying all this. I mean, the things that I do, for instance, is amplifying my good experiences in the healthcare system,
Wonderful.
right? With
That's
people
right.
that I love, that I care about, who may have a negative experience, you know, for
That's
what
right.
it's worth. But I do think that that's something that could go a long way.
Absolutely. Absolutely.
So I apologize for the rest of the questions. We ran out of time, but I think this is a good note to end this with. Dr. Ojikutu, you were fantastic. Thank you for your insights and your wonderful, you know, thoughts and solutions. It was all very much grounded in your amazing research and experience. And thank you so much for sharing that with us today. And thank you to everyone who joined us. And please feel free to continue this conversation that we're going to have in Health Equity Week. And I hope you join us. Thank you so much, Dr. Ojikutu. Again.
Thank you, Marcel, for having me. This is wonderful work that you're doing, and I really appreciate being included.
Thank you.